And now I'm going to start the webinar. Okay. Welcome, everyone. It looks like we have a few people joining in. We will start in just a little bit. I'm gonna wait like 10 more seconds, just so we're right on the dot. All right, welcome to the premiere of Growing Stronger's 𝘾𝙊𝙉𝙍𝙍. We are here tonight with Dr. Klane White, who is the director of the Skeletal Health and Dysplasia program at Seattle Children's Hospital. He is the professor of orthopedic surgery at the University of Washington and a diplomat of the American Board of Orthopedic Surgery. Dr. White is an internationally recognized expert and advocate in the care of, I had this so down earlier, 𝘾𝙊𝙉𝙑𝙀𝙍 and skeletal dysplasia. And he serves on the medical advisory board of Little People of America, and is an executive founding member and the current president of the Skeletal Dysplasia Management Consortium. I am next going to have Growing Stronger co-parent founder, Munira, give her introduction.
Hello and welcome. My name is Munira. Along with my husband, I am the co-founder of Growing Stronger. We live in the San Francisco Bay Area. Amin, one of our children, was born in 2008 with the most common form of dwarfism, achondroplasia. Since his diagnosis, it has been our family's mission to help improve the quality of medical care for those living with achondroplasia by supporting research and through science, empowering health and education. Thank you for joining our premiere episode of 𝘾𝙊𝙉𝙍𝙍. Back to you, Chandler and Dr. White.
Great. So as I mentioned, we're here tonight with Dr. White, and we are discussing new frontiers and growth therapies for achondroplasia. We had many of you submit many questions beforehand, which are great. And so tonight we have the honor of going over those questions and having a conversation with Dr. White about new frontiers and growth therapies for achondroplasia. So Dr. White, if there's anything else you would like to maybe say before we get started.
Of course. No, I am honored to be the inaugural guest for 𝘾𝙊𝙉𝙍𝙍𝙍, right? And I would like to really give a shout out to Growing Stronger as an organization. Our group, the Skeletal Dysplasia Management Consortium, is a group that's really organized. It's a group of clinicians who our goal is to put out information to both caregivers, providers, and to families, ultimately, through a little more time, that will improve the care and quality of life of those individuals who have skeletal dysplasias. So Growing Stronger has been a very significant partner with us over the years, which, at least for the last 8 years that we've been in existence. So I want to thank you guys for having me and for your support of our efforts to help improve everyone's lives who are affected by skeletal dysplasia.
Awesome. Well, as I mentioned, we had many of you submit a lot of questions beforehand. And so tonight we will be going over those questions, ranging from access to benefits, research, and even orthopedic management. So to kick off our questions, we will be discussing access. Our first question that we had was, when will the Sorotide be available to children under the age of 2?
Well, that's
the hottest question.
I don't know. There's still, as far as I understand, that data has not yet been submitted to the FDA. I could be wrong about that. I know right now the 2 to 5 year old data is probably being reviewed and perhaps being sent off. Under 2, I'm not sure. To be honest, I was not involved in the under 5 studies. I was only involved in the 5 and over studies. So I would imagine, though, given the safety profile and the expedited approval of a Sorotide, that it is not too far in the future, maybe a year or 2 at most.
Are there any, have you been able, or are there any pros and cons of the therapeutic treatments that, you know, are available or being currently researched right now?
Yeah, you know, Sorotide is just one of many options that have been introduced or are under investigation right now. So there are other companies that have similar medications, or actually other medications that act through different pathways, biochemical pathways, which can, I guess, accelerate growth in achondroplasia. But there's also the old tried and true surgical interventions, right? So there are many ways, and I think the benefits of growth therapy and I would include that surgical therapy, so medical therapy and surgical therapies. You know, I think that's a very personal decision, and there's no sort of data to show that it improves quality of life or long-term health outcomes for any of these. But what it does do is it does sort of change maybe perhaps your self perspective, your ability to engage with your environment and your community with or without other devices, apparatus, for like our children who needs, stools to keep their feet on the ground at school, or to get up to touch elevator buttons, or to reach countertops that are built for average statured adults. I could go on and on with sort of the practical reasons why it might be improved, why life might be improved, but we just don't have it. I can't say there's a scientific answer to that question. So it really, at this point, comes down to, an individual perspective, I think.
Mm-hmm. Right. I know all families have, every family has, their different lifestyles. And I think that's important that, families all do what they feel is best. What age do the therapies typically start? And again, I'm sure everyone is aware that all of these are trials right now, or most of these are trials right now, but what age do the therapies start, and are they developing therapies as a subcutaneous injection?
Well, the current Sorotide is a subcutaneous injection.
Right.
So, and I think the other forms are all subcutaneous injections as well. There's 2 other, there's 3 other medications that are under investigation right now. I'm not part of the trials, and I'm not overly familiar with that medication, but the 3 that I've been involved with are all subcutaneous injections. The age ranges are, 𝘾𝙊𝙉𝙑𝙇𝙊𝙑 has been working on the birth to 2 group. I work with Ascendis right now, and they are down to age 2. And we're still waiting for Theracon. I'm not sure where QED is with their trials right now. So in terms of what ages, but as far as approved therapies, right now it's 5 and up in the United States, in the European Union. And I don't know that it's been approved anywhere else. And if someone knows better than that, then I'd be happy to be educated on it. I just don't know. As far as surgical interventions, I think most people try and wait until the children are probably 7, 8, or 9 years of age. There are advocates for younger children, and I think there's pros and cons. But but the surgical interventions take a long time. It's usually at least 2 years of surgical interventions. And it really comes down to, it's less of a technical issue and more of a, when is a child emotionally and developmentally ready to undergo which is a pretty demanding intervention.
Mm-hmm. Oh, I've never heard that phrase like that, a pretty demanding intervention. I like that. I've never heard of that.
Yeah.
Hang on. I have the list of questions. If someone said, I am just looking for general information on the new therapies, when should my child is 7 months old, when should we start pursuing, and who should we see to start the process? And I guess, they're wanting what's available now. What would be the best way to go about starting that process?
Yeah. So I have these conversations with families. We probably have probably 4 to 6 new achondroplasia babies, come to our clinic every year. So these are conversations that we have immediately because families want to know, and I try and tell them as much as I can and where we are with things. So I don't think it's ever too early to start asking the questions. And theoretically speaking, any of these medications, the earlier you start them, the more likely they are to have medical health benefits. Again, there's no science behind that yet. We're waiting for that, and we might not even know for many years. Mm-hmm. But it just makes sense that there's a lot of development in the skeleton that occurs before age 5 that can't be addressed after age 5. So if you start at birth, then there may be some true benefits. Now, are there side effects that we don't see in older kids? I don't know. Again, we don't have that information. So who would I ask? I would ask someone who has a clear experience in taking care of children with achondroplasia, and preferably a center where they've participated in some of these trials and have a deeper understanding of what it means to start these therapies.
We have a lot of our followers who are, of course, outside of the US. And so a big question that we get a lot, or that we've seen a lot from families, is, when will these therapies be released for the mainstream? I live in Australia and have a 6-year-old son with achondroplasia. And so, for everyone's wondering, when will they have it available where they live?
So I can't speak to the different governmental processes. And it also has to do with whether probably the government is paying for this or not. It's a very expensive therapy. And I think if the government is footing the bill, say in Canada or the United Kingdom, Australia, I think has a mixed model. That's going to determine whether they're going to approve it or not, I would guess, because it wouldn't make sense to approve a therapy and then not pay for it. Mm-hmm. And as Chandler, as you kindly reminded me, I'm the warm-up act for Dr. 𝘾𝙊𝙉𝙑𝙑𝙑𝙑𝙑𝙑, and he is from Australia and has been really the clinical leader for a lot of these trials. And I'm sure next month he could probably answer that question better.
Right. That is for all of those who are on live right now, Dr. White did just announce our next That's good. Our next episode, which will be with Dr. Robbie. But what you just actually said kind of answered our next question, which was, with how, with the rollout, how do we get access in the other countries? And that was from someone in South Africa. But what you just answered for that other question, I think that answers the next question. So I guess, now we can kind of sort of get into the questions over benefits and what, so I know a big question is, how will these therapies help when it comes to spinal stenosis?
We don't know. Right. Is the short answer. The long answer is that So spinal stenosis is determined by the diameter of the spinal canal. And so when the spine grows in several, the spine bones are three-dimensional. And so they grow in height, and which is not so much of a problem in achondroplasia. Most people with achondroplasia have near normal trunk heights, right? So, but what doesn't grow is the front to back dimension. And so if you look at a vertebra from the top, you have the body in the front, and then you have a canal in the back, and the spine, all its neural elements go through that canal in the back. And so if in achondroplasia, that is smaller. So there's a shorter distance and a smaller canal. The growth of what we call the pedicles, which would be my fingers in this case, those will grow until on average about age 5. Mm-hmm. So if you start the therapy after age 5, and this is what I was alluding to earlier, then the benefits to spinal stenosis are probably very limited. So the $100 question here is, how much benefit do you get from starting earlier? Mm-hmm. And how early do you have to start? Is starting at birth early enough to make a significant difference? If we're talking about lumbar spinal stenosis, I think most of us feel that that's a reasonable expectation, but we don't know the answer to that question. Now, with regard to foramen magnum stenosis, which is a problem that we deal with at birth, in the first year of life, there's no way you're going to get enough growth of the foramen magnum, at least in my opinion, to obviate that problem. And so I don't know that even if you start medication at birth, that you're going to be able to fix that. Now in the very distant future, who knows, maybe we'll even be able to start treating prenatally. And that might be enough to affect a difference. But this is, highly speculative and into the future. I don't have a crystal ball, so.
Right. And again, I know, we all know there's very, limited data out there right now in terms of, the long-term effects, but currently, do you know about how much height is to be expected to be gained from taking these therapies?
Yeah, I think we have pretty good data at this point. So I think, first of all, one thing is that the growth response, and I'm speaking specifically to Sorotide, because that's the only one we have published data on at this point. So Sorotide seems to work effectively no matter your age. So you can be into puberty, you can be 5. It doesn't matter. The response is about 1.5 centimeters per year of growth on average. Now remember, that's an average, so some people did better, some people did worse. And so if you think about a 5-year-old who starts therapy, we know achondroplasia girls will grow until about age 16, and boys will grow to somewhere between age 17 and 18. So you can expect that growth acceleration to last, at least we hope, throughout that time. So that would be for girls 11 years and boys 12 years. So you can do the math. It's going to be 15 centimeters for 10 years, and then another 1.5 centimeters per year after that. So 16.5 centimeters for girls, and then another so it'd be 18 centimeters for boys, right? So starting at age 5. So if you think about it, if you do it, if you're more prone to inches, which most Americans are, and I'm not sure how much what the mix is, the audience is, that's a 6/10 of an inch a year. So that would be in 10 years, that would be 6 inches. Mm-hmm. Okay. And then if another year of growth would be 6.5 inches, and for 2 more years of growth in a boy, that would be about 7 inches of extra growth.
I know the whole inch to millimeter to centimeter comparison when talking to people in other countries, I'm always embarrassingly on Google, inserting it to make sure I'm like saying the right
Yeah.
their measurement that they've asked about. And I'm just like, I am so used to inches.
Well, yeah. And I always have to, to be honest, I always have to either pull out my phone and do a conversion, or, what I do is I cheat in clinic because we have the stadiometers, the little height measure things on the wall. And you can just look at the centimeters on the left and the inches on the right. And then, okay, well, that's that. So,
like, I remember learning that in like 5th grade or whenever, but after that, I forgot how to do that.
Yeah. But in healthcare, we talk about we use, for the most part, centimeters. So anything you see published is going to be in centimeters. And the average height for a girl with achondroplasia is 125 centimeters at maturity, and the average height for a boy is somewhere between 130 and 135 centimeters. And so we'd have to go back and do the math on inches on that, which I don't have at the top of my head, but from there you can kind of figure it out.
Yes. Sorry. So this one might be, more personal, but the question was, how do you feel about the Sorotide, and can you get a bigger benefit? You've covered this earlier, but can you get a bigger benefit if it started earlier at 1 to 2 years old? And would the potential gain in height, again, I think you've already answered these, but would the potential gain in height be greater if the drug was used for a longer period of time? And does it help with other potential health issues for achondroplasia?
Yeah. So again, yeah. So, just to reiterate, we don't have data below age 5, but there's no reason to believe that that the effect would be any different. And it could be even more in the younger children. Most children have between age 0 and 3. That's one of the times of highest growth velocity. So then for children with achondroplasia, they don't really see a pubertal growth spurt like you do in average statured children. So, but you do see a bit of it when they're younger. So there may be some accentuation of that. So clearly the longer you take it, then the more likely it is going to increase stature. As far as the other health benefits, again, if the younger you start, then the more likely it is to have some health benefit. But again, we don't have any data to support that. That is just, but if you ask, so I've been part of an expert opinion panel on this, and that's going to be published at some point, probably in the next 6 months. I think most of us believe that there will be increased benefits by starting at a younger age. And what do I personally believe? It probably doesn't really matter what I personally believe. Again, this is a personal decision, but I do caution, and I know there's a question about a 13-year-old or something in there. And so maybe we can just address that issue now. You have to decide, is it, if you're 13 and you're a girl, or even if you're a boy and you're going to grow only another 3 years, and you're going to gain 0.6 of an inch per year, a centimeter and a half per year for 3 years, is it worth getting a shot every day so that you can grow what would be less than 2 inches more than you would grow otherwise? Right? Mm-hmm. So I think in that scenario, to be clear, I've had 2 patients who are that age who elected to proceed. Mm-hmm. I'm very honest and candid with them that I think the benefits from quality of life and are limited. I mean, it's a very different scenario than saying, I'm 5 and I have 11 to 12 years of growth versus I'm 3 and I have 3 to 4 years of growth. So the benefits, I think, certainly are less if you start later. The later you start.
Right. I feel, sometimes I feel like that's the same with surgery. I mean, just because given my own experience, I always say I wish the orthopedic procedures I went through, I wish I had started sooner because, life gets, 1, busier as you get older, but 2, and especially what I've heard, for girls, sometimes bone growth is a slower process than it is for boys. And so it's just like, again, it always depends, on the person's lifestyle and, how, that plays out. But besides, and I know this may, again, go in with the, the limited data that there is, out there and what's not out there. But, aside from height, are we seeing these therapies also affect arm and leg growth?
Yeah, so that's a really important question. And the data so far would suggest that arm and leg length, so proportionality, as we sort of think of it, is normalized. And I use that in air quotes. It's more towards average body proportions, right? So if we think about arm length relative to height as a proxy for both arm and leg length, and actually in these studies, they measured leg lengths as well. You see, so an average statured child, most infants and under age 1, your trunk to legs proportion is close to 2 to 1. Your trunk is twice as long as your legs and your arms, right? So, but as you get older, that by age about 7 or 8, that becomes 1 to 1. And achondroplasia, that never really changes. It stays 2 to 1 for your whole life. Now, and we can measure differences from typical or average by what we call standard deviations or Z-scores. And so what a Z-score just says, if you're 1 Z-score, then you are, you're within 60%, 67% of the average. And if you're 2 Z-scores, you're somewhere around 90 percentile, right? So we're thinking about, who's the 10th percentile there. So what they found was that with achondroplasia in the study subjects for Sorotide is that their Z-score was like -2, 2.5, meaning that their arm and leg length relative to their trunk was very short. Mm-hmm. Okay, and that number improved into the 1.5 range over the course of a minimum of 2 years. So some of those subjects were only 2 years, some of them were 3 or 4 years out. And you could see demonstrable differences in that. So it does seem, that's a very long-winded explanation to say that it does seem to affect proportions in what would be considered a beneficial way. But how sustained are those over the long run, and does it ever get to that 1-to-1 ratio that we see in average statured adults? That's unclear.
And you sort of answered this one, the question before this one, but just to circle back, they're wondering, is it worthwhile to start these therapies if my child is 13 years old with only, so many years of growth left. And so
so I know I kind of answered that, but let me just say that I have, so I have 3 kids in the trial here for Sorotide, and they all started when they were about, 8 years of age on average, 7, 8 years of age, maybe 9. And so now they're all 12, 13-year-olds. And all 3 of them asked to stop. Mm-hmm. Now, 2 of them, we talked to them and I said, do you really want to do this? Let me explain. And this is, I showed them their data and assured them that they were actually getting, they were seeing an effect from this, which they would assume to be beneficial because that was what they were after in terms of accelerated growth. But one decided not to. She was like, she just said, I've had enough. I don't want to do the shots anymore. So that just points out, highlights the individuality of this, and some children are much more okay with having daily injections and some are not. Now, with that said, one of the therapies that's coming down soon is the more or less the same drug as Sorotide, but it's a once weekly injection. So that might, we don't know if it works as well yet, But if it does, then that might be more palatable for kids.
And sorry, I was answering a question. What's the perspective for a baby with achondroplasia who starts growth treatments before the age of 2? Again, I know, we all know that's not approved here in the US. And are they going to reach 1.5 meters proportionally by the time that they are 18 years old?
Yeah. So again, I don't know what the data is on the 2-year-olds, but theoretically, if you extrapolate the data from the 5-year-olds and older, then a 2-year-old, and I've already mentioned the average stature for girls is 125 centimeters or 1.25 meters. And so if they are to gain, if you do that math, that's 13 years. So that's going to be, and I've already done this math in my head, but now I forgot it. But I don't think the girls are going to make 1.5 meters. The boys, I think, could.
Okay. It's good to know. I think that kind of went over our questions over benefits, and even a lot of the research questions that we have, that I feel like they're all kind of the same last few questions that we just went over, which is, is there preliminary data for the studies that are being performed on infants? And if so, what is the dosing schedule?
Yeah, so I would presume the dosing schedule is the same.
Mm-hmm.
It doesn't change. It's going to be a once daily injection for Sorotide. We did, that data is not public.
Mm-hmm.
So I cannot, and I don't know it. So
I feel like I'm asking you all these questions that, top secret for everyone. And so, but it's unfortunate, but we know, that's what everyone wants to know.
I think the companies can't, they legally cannot say so.
Right, exactly.
And I think, it would be irresponsible to try and, speculate too much.
Right.
But yeah, again, as I mentioned, I think most people who have expertise in this field think there would be benefit, as I've already outlined with regard to spinal stenosis, maybe even some craniofacial aspects with regard to obstructive sleep apnea. So who knows?
I know, so we do have several orthopedic related questions, but I also know we've had a few people submit questions in the chat. If we wanted to go over those first, which is and this kind of mixes with, I feel like, the therapies and orthopedic. Comparing the subcutaneous injections to limb lengthening, what would you say on a variety of considerations? Example, invasiveness, complications, risk, time, cost, etc. I guess, what would be the way to go? I think that's what they were asking. They didn't end it in a question, but I think that's kind of what they meant.
So this is in the chat.
Yeah.
Comparing subcutaneous with limb lengthening surgeries, is that, so what is sort of the pros and cons, probably, medical therapy and surgical therapy? Okay, so personally speaking, I would rather have an injection once a day.
I too.
Yeah, that's assuming you get the same outcome though, right? I actually have not seen, well, people have published on sort of outcomes with limb lengthening. I don't know what, and maybe Chandler, what the expected growth is, can be. And the problem is with surgical interventions, it's not always reliable. So some people have what we call premature consolidation when they're trying to lengthen, and then it fails, and have to start over and or quit. Surgery is surgery. And there's a saying in orthopedics that there's nothing surgery can't make worse. You can end up with a nerve palsy. You could end up with infections. In fact, you're guaranteed to have a appendicite infection.
Right.
We do have intramedullary lengthening devices now, but you can fracture through the lengthening part. There's a fair, as I said before, it's a very demanding intervention. And so, you know, it on average, it's probably at least 2 years worth of surgical interventions, if not more. So, and at least now, you know, it's not quite as bad because it's not all circular frames like it used to be. But still, there's that amount of time where even if it's an intramedullary magnetic growing rod, there's a certain amount of time where children cannot participate in play. They can't be active for fear of breaking something or otherwise, you know, causing a problem with the lengthening. So, so it's, you know, for me, I would rather the injections are very well tolerated. There have been minimal side effects noted, just some injection site reactions, a little bit of low blood pressure on a small number of people, which can be mitigated by just taking it at night before you go to bed. So for me, I think that's probably the benefit. Now, as far as cost, you know, this drug is expensive and it's about $300,000 a year. So you could probably do most of your surgeries and have in you know, over the course of those 2 years or whatever it is, and the total cost of those surgeries is going to be, you know, certainly probably less than $500,000, but it's going to be expensive to someone. It may not come out of your own pocket, but it's going to come out of someone's pocket. But if you do the math, you know, if you're talking again, 10, and I just like to use the 10-year because the math is easy.
Yeah.
And so if you think about 10 years of therapy, that's $3 million on Sorotide. Okay. Versus, you know, $500,000 for surgery. So there are other examples where, you know, where there are medical options, but surgery, well, I should say, well, or medical, well, another example of this would be like enzyme replacement therapy in the MPS disorders. Well, you can do a bone marrow transplant as higher risk. You know, it's like a 10% more mortality rate with bone marrow transplant, but it's one time and it's about $1 million versus enzyme replacement therapy, which like Sorotide is on the order of, you know, $200,000 to $300,000 per year. And it goes on for the rest of your life. So, you know, these are the kinds of the pros and the way you have to think about these pros and cons. It's not easy math, to be honest. Right. And then again, it comes down to what's your tolerance for surgery and what's your tolerance for injection and what are your resources. So
that kind of how you were ending that, you know, with the numbers kind of goes into this one question. I have heard rather high expense numbers related to Voxelgo, not our first consideration, but is there any indication on how much insurance companies are covering, and is the insurance process difficult? Are there any prior authorizations that are required?
Oh yeah. So I will say that we've started 4 or 5 kids now on Sorotide, and I mean outside of the study. And we have not had it. What's the word I'm looking for? Refusal, I guess, a declination by the insurance company to pay for it, but they certainly have required pre-authorization, and we've had to write multiple letters of necessity for that, or support, really. Because to be honest, it's hard to write a letter of necessity for growth therapies in general, not just for achondroplasia, but, you know, what are the, you know, it's not like you're going to keep someone from dying with this, right? You're talking about someone's quality of life, which we're kind of used to in orthopedics, because most of what we do is quality of life related. It's not life and death. But, you know, I think these letters can be written, and it really comes, you know, and I will say, you know, not to be a shill for BioMarin, but they, you know, they do make the process easier, and we work closely with them because they provide us with a lot of support to help get this through, which is in their best interest, of course, to get people on drug, right?
I know this one is one that's probably, in due time. And so it's something we won't know about for a while, but someone asked is when will Voxelgo be a pill?
I don't know. The Voxelgo will never be a pill because then it won't be Voxelgo. It'll be something different. So I saw one of the other questions was about what is this medication? How does it work? Is it a growth? It's not, so Voxelgo or Sorotide is a peptide. So it's a small protein. All right. So if you think about if you eat steak and it goes into your stomach, what happens to it? It's protein. It gets broken down. Our gut is really good at breaking down proteins into their constituent amino acids. So that's what happens to any kind of peptide or protein you eat. And so you have to encapsulate it in a way that then can be taken up from the gut without in a protected fashion and then be released into the system. I'm not familiar with that technology at this point, but I would imagine, everyone would rather have a pill, but, we've been doing growth hormone, which is a true hormone, for 30 years. It's still an injection. Okay. So I don't know that will ever change.
Right. Is there, and these are two questions from two separate people that I feel like maybe they can
sure
go together. Is there any data available from human trials and any of the other non-Sorotide treatments at this point? And then the one after that, are any of the therapies, in trial in a stage 3?
So phase 3, yeah, phase 3. No, I wrote stage 3. It's phase 3. So yes, no, so Ascendis's drug is in phase 3 trials. It's a combination phase 2, phase 3 trial. So they did a dose escalation, and that's now gone to open label, which means that they've determined the dose. And so now they're doing the safety evaluation for that. And so I would imagine that therapy will probably be submitted to the FDA sometime in the next 6 to 9 months. And that's the Sorotide. It's not Sorotide, it's CNP, sorry. Sorotide is very much Sorotide. So this is a C-nitrate peptide analog as well, just like Sorotide, except it comes in, it's a unique technology in which it's in sort of a little bit of a molecular cloud. And so it gives it a slower release in the body. And so that's the injection. Theracon's drug is not, they've had some holdups in terms of its entry into phase 3 trials. And I'll be honest, I don't know where QED is. They have another therapy, and that's what we'd call a tyrosine kinase inhibitor. So the way that works is so FGFR3, the receptor that has the mutation in it, is upregulated. So it's a little bit backward. You have to think about it. It's upregulated, which then reduces growth. So this inhibitor, so FGFR3 works through a tyrosine kinase inhibitor. And so by inhibiting that tyrosine kinase, you are downregulating the FGFR3 again, and therefore promoting growth. That's that drug. I'm not sure where it is. And just to be complete, the Theracon drug is what we call an FGFR3 analog. So it then binds the FGFR3 receptor and downregulates it that way. So it's a competitive, or I should say, it's a competitive inhibitor. So it inhibits the growth. So those are the therapies that I'm aware of that are certainly close, if not in trials or close to trials. And I would say the closest one is probably the Ascendis therapy, and it is, I would say, at least a couple years off from FDA approval.
Right. And I just want to make note, because I'm guilty of it too, but Theracon now is Pfizer, but I'm also, and I know we all know that, but just if there's anyone on here who's like, what's Theracon? That's Pfizer's, now Pfizer, but I
had for the hardest time, I kept mixing up which one Pfizer bought, and I could, so.
Yeah, I still call it Theracon though too. And so it's just like, sometimes I have to catch myself or remind myself that like Theracon and Pfizer are not like two separate things.
Yeah, they're the same. Yes.
Yeah. But so I just wanted to, make that clear if there was anyone who's like, I've not heard of Theracon. Yeah. I guarantee you have. What was the next one I had? Someone asks, I think they currently do receive Voxelgo. Does it need to be refrigerated if you get a 1 month supply? They say that we do get a 30-day supply, but we don't refrigerate it. Is that okay? Right.
Yeah. So until you reconstitute it, I think it can actually be out of the refrigerator for up to 90 days. Don't quote me on that, but it's definitely, it lasts more than a month. But they, for whatever reason, I think it has more to do with insurance. They are not shipping more than 30 days at a time. So, but once you reconstitute it, I think it needs to go in the refrigerator because it comes as a powder. Then you add the saline to it, right? Mm-hmm. And once you reconstitute it, it has to go in the refrigerator, I'm pretty sure. But there's no real reason to do that because I think the vials are individual doses. So you just reconstitute it, pull it up, and then you inject it.
We just had another one. Other than transient, am I going to say that right? Diuresis. What adverse effects are seen with the I cannot speak tonight. Natriuretic peptide analogs.
We can just say CNP.
Thank you.
So I did not hear anything about diuresis. Mm-hmm. It's a transient hypotension. So the natriuretic peptides are, so there's A, B, and C, right? There's A, natriuretic peptide, B, natriuretic peptide, and C. Now they have a lot of different roles in the body, but A and B are actually very active in vasodilation in the expansion of the blood vessels, which can then reduce your blood pressure. Now again, we saw only, so if you look at the data, 13% of subjects had a transient hypotension where they felt a little lightheaded, compared to 7% placebo. So, some of those, it's hard to know how much is, we know some of that was placebo, some of it was true effect. The other, again, the only other significant side effect that we saw was injection site reaction. So redness, soreness, which tended to go away after a day or two at the injection sites. Nothing else really panned out to be significantly different from placebo.
Going back kind of to the orthopedic side of things, because I know we do have a few orthopedic questions. One person asked, my son is 12 and his legs and hands are bowing. Is there any therapy that he would benefit from? If not, what else can or should we do?
So, at this point, so let's just be clear, first of all, bowing of the legs and arms is not a problem in most children with achondroplasia. Maybe, 15 to 20% of kids will end up having some leg pain, which may be responsive to treatment. Now, will these medical therapies address the bowing? We don't know. Probably, we don't know. But I would guess, if you started early enough, it might benefit the bowing, but certainly not after age 5. And at least we haven't seen that. And that's going to be a good question long term that we can go back, because we've obtained X-rays and measurements on all these kids, and the FDA is requiring that all of these companies follow these kids long term. And so, at some point we'd like to go back and do spinal measurements and do leg measurements to see if there was any benefit in that regard. So I guess really, but to answer the question, what can you do about that? For the arms, I don't know. I mean, the bowing in the arms is really insignificant in most cases, unless you're talking, we're talking about, usually it's the elbow can't get all the way straight.
I'm assuming that's what they meant, was the elbow.
Yeah, because we don't see bowing this way.
Right.
Like the legs where you see bow legs, or even sometimes knock knees, more or less commonly. But actually, I'm giving a talk next month at the Pediatric Orthopedic Society of North America on what we call guided growth for skeletal dysplasia, and I will say that I've had surprisingly good outcomes with achondroplasia. Historically, we always thought, well, with achondroplasia, you don't grow fast enough. It doesn't, so it probably isn't going to work. But this, what we call tension band plating, more commonly known as 8 plating. That's like, tissue paper versus Kleenex, right? So it's one's brand name and one's sort of generic. But so tension band plating, even I've done it as late as age 12 with excellent results. And it's for the most part, it's a minimally invasive procedure. In the old days, we would just cut the bones and realign them because we didn't think there was enough growth to do the growth, what we call guided growth. So that's where I would hang my hat at this point for that. Yeah,
we may have to have you back on an episode to present that presentation that you're going to give. Sure. That might be good for the parents. And then the follow-up question is, can these therapies be taken while also going through limb lengthening?
Well, there's no rule that says it can't.
Right.
And I would imagine the benefits would be additive because the biology is the biology, and with the mechanical changes, if you think about it with a limb lengthening, they're not mutually exclusive. And there's no reason to believe that these therapies would inhibit bone healing, which would be my only real concern.
Yeah.
If you're doing a limb lengthening, you're relying on bone healing. And so if there's something that would impede that healing, which would then make the outcomes compromised, that would be my only concern. But I have no reason to believe that these therapies don't act on bones; they act on the growth plates, which are made of cartilage. So I would have no reason to believe that you couldn't do that.
Someone asked, can you do limb lengthening at a later age, like 15?
You can do limb lengthening at any age. You can do it as a fully grown adult. And I've not seen it done much in children under age 4, but I have seen it done in children as young as age 4 or 5. Some people believe it's better to do it at that age when they're a little bit more, intellectually and cognitively pliable.
Yeah.
Again, this comes down to, and their benefit would be that, if you're, if you're a tween or a teen, and you're in middle school and high school, I mean, that's schooling is much more important. I mean, if you miss a year of preschool or kindergarten, who cares, right? You're not really missing that much, let's be honest. So there are, theoretically, there are some benefits. Now, where I trained, the person who did all the limb lengthening, he was a firm believer that children just weren't emotionally ready until age 9 or so. I don't do limb lengthenings. It's not my gig. So I would defer to those experts.
Right. And just to answer that, actually, that, one from I kind of have a question or answer to that one. And the one that we just asked was, and I don't want to quote him since he'll be our next episode, but I had actually asked Dr. Ravi that question about the Sorotide and limb lengthening. And he had said, he, sees no reason why you would do 2 together because you can always do lengthening. So it's kind of like, why would you, want to do both at the same time, which that's how I see it as well. And he, I know he said, wait and see, if you're going to go through the therapy, do that by itself to wait and see, where you are by the time your end of growth, and then make that decision rather than, why do both together. And that's how, that's personally how I feel that way too. And I know we meant to start with we only have about 5 minutes left, and we meant to start with our kind of like get to know you questions. So since we only have about 5 minutes left, I think Manira wants to, kind of, so everyone can get to know who we spoke to this evening with Dr. White.
Yeah, well, I mean, so I guess a little personal background. So I'm in Seattle, as you already mentioned, and I had the skeletal health and dysplasia team here. And I think my whole career is pretty much oriented to, caring for kids with genetic skeletal differences. And I will say that is large part is due to the fact I had a daughter who had Hurler syndrome, a form of MPS. So she was, she died unfortunately when she was age 9 due to complications. She had a bone marrow transplant when she was 1, but she never really got over it. And but she was 9 years old and she was 3 feet tall, and she was, I think, she might have been like 35 inches, really 34 inches, but 3 feet's easy to remember. So but anyway, so she definitely had genetic skeletal differences, and that sort of really sort of sparked my interest in these in these kids, and now adults as well. I feel like I can help adults at least answer questions and help. And while I don't really operate on adults, I certainly have a better understanding of what they're going through than any of their, primary care doctors or adult physicians for the most part. So I like to put myself out there for people who have questions, and, try and help people understand, this quickly changing landscape of medical and surgical therapies. So.
Manira, do you want to kick off?
No, that's great. This has been a great conversation. Thank you so much, Dr. White. I really appreciate the time you've given us today. Your personal story in the end was very heartwarming. We just wanted our attendees to know that we wanted them to learn more about their options today that are, as you said, rapidly changing, and also there's so many orthopedic issues that keep coming up over and over again, notwithstanding the therapeutics that are available today. So thank you for addressing some of those as well. We really appreciate you today.
Yeah, my pleasure. And I really am honored to tell Ravi that I was the first guest.
Yeah.
And, he was the second, so, that he can.
He was excited that you were the first one. He was very joyful when we told him.
Yeah, we have a lot of, go between, in case you didn't notice. So,
yes.
Yeah, so I will look forward to your next A conversations with Dr. Ravi, as he likes to be called. And maybe I'll get on and give him a little hard time through the chat box.
Definitely. I encourage it.
It's been a lot of fun.
Great.
Thank you.
I guess, we're almost at the top of the hour, the end of the hour. So we want to thank everyone. We have so many thank you, Dr. Whites, coming into the question box, but we want to thank Dr. White so much for being our, inaugural big time guest for Growing Stronger's, rebranded LP Doc Talk, which we are calling A Conversations. We will definitely have to have you back for more episodes. We might need to have an episode with both you and Ravi together. I think that would be a hot, I think that would be a really hot topic episode. And so again, we did record this session just to let everyone know, and we will share it with everyone and have it posted on our socials in due time. But we just wanted to, again, thank you so much for joining us this evening. 𝘾𝙗 from Growing Stronger has posted in the chat. He wants us to tell you hi on his behalf. So hi from 𝘾𝙗 to Dr. White. And
yes.
so thank you.
Right back at you. Right back at you.
Thank you, everyone.
All right.
Perfect.
All right.
Thank you.
Thanks.